Welcome to the JEMS Report, brought to you by Clarion Events, Fire and Rescue Group, and the Journal of Emergency Medical Services. My name is Ted Lee, and I'm the editor-in-chief of JEMS Magazine, along with Jeff Frankel, our managing editor. We will be bringing you subject matter experts and industry leaders to talk about all things EMS. And today, our very special guest is Dr. Michael Carr, Executive Director of Prehospital and Ambulatory Services, Virtual Emergency Services, PAVES. Thank you for joining us today.
Thanks for having me. It's great to be here.
So why don't you start off and give our audience a little bit of your background and kind of outlay who is PAVES? That's quite a long title. And tell us a little bit about what you guys do.
Absolutely. So my name is Michael Carr. I'm an emergency physician and EMS physician at Emory University. I've been on faculty since 2018, and in the role of EMS and disaster medicine, I'd say most of my work is outside of the hospital. Early on in my career, actually during my fellowship, I gained a particular interest in telemedicine, specifically all virtual care that could be brought to the field to enhance patient experience, optimize resources, and in essence, make the system more efficient. So I started right out of the gate in 2018 and started, looking at various grants and opportunities to support research. I always have to tell the story early on in the pandemic. This was March 2020. I was infected with COVID. I think I was the first person in my physician practice to be infected. So naturally, I was banned away in the second bedroom of my apartment for 2 weeks. Nobody knew what to think. That was a silver lining of the pandemic for me, right? Because I had a lot of time to sit down and work on a grant proposal. And I particularly got interested in the rural disparity and how we could potentially use virtual care to support that disparity and focus on improving outcomes or really reducing time to definitive care. That was really where I developed my interest. Thankfully, I was successful with a HRSA grant proposal. HRSA is the Health Resources Services Administration, and I was accepted as part of the Telemedicine Network grant program to build out a telemedicine network in rural Georgia. And we can get into the particulars about that, but there were various needs around the state that we were able to meet with a virtual care network.
Well, as you mentioned, early on in your career, 2018, the pre-COVID time, I know that telemedicine was something that was talked about. There were items where, we think this could work in certain areas, and then COVID really forced it on us to where, we really had no choice. But to your point, for Georgia, rural medicine is really taking off with some of this telemedicine. Don't you agree?
Absolutely. And you hit the nail on the head. I think leading up to the pandemic, looking at the use of telemedicine and emergency medicine, it was really limited. If there was any research or experience described in EMS, it was usually telestroke or, in the case of emergency medicine, telebehavioral health. So those were kind of the two teles that we saw, and there were some programs that were successful. My mission was to develop a program that was more acute care focused or time sensitive focused. And that was, I would say, that was the difference or the change from what had already been done. But yeah, it's virtual care became a necessity in the pandemic. As you may have noticed, we see that pendulum starting to swing back. So now it's trying to fight to show we actually made an impact and a difference. Right. And it's not easy.
Right. It's funny you mentioned the pendulum, because I use that example for a lot of things. It's, we always swing the pendulum as we are adjusting to things, and we never get it quite right the first time. There's always an overcompensation for it, and then we start to bring it back. And, as we have more data and, we're looking at the research and we're looking at the capabilities, a lot of people are looking back at the COVID times and saying, well, we had to do it then, but that means, we were successful in doing that. So that means we can still do it now. And then what else can we do with it? So I'd like to hear, what you guys have worked on and how you're advancing this, from post-COVID, now that we're back into a little bit of normalcy, people trying to get back to what we used to do.
Right, absolutely. Yeah. And you say normalcy. I would say most of the conversations about trying to justify the role for virtual care and EMS, everybody's, that's what I hear the most. Oh, we're pretty much back to normal now, right? So,
right.
If there is any version of normal, to give a little bit of history, in 2021, we deployed our first ambulance in rural Georgia. We had a partnership with an agency that at the beginning of the grant was exclusive. We had 16 counties across the state. And by the way, there are 159 counties in Georgia, and about 75% of them are rural. So we had 16 counties that we partnered with through this EMS agency, where we could deploy telemedicine equipment in the back of ambulances. So that was a tablet computer. We had a noise canceling microphone speaker mounted to the wall. Those were all mounted to the side of the ambulance. We had a pan-tilt zoom camera in the ceiling, and the monitor defibrillators that we were using could connect via Bluetooth to the tablet. So we could stream all of the vital signs and see what was happening with the patient remotely. When that equipment was installed in several counties, we started to learn there were different needs, and therefore we developed almost different experiences with virtual care. In a nutshell, once the equipment was installed, these are primarily for 911 calls. Crew would respond to a patient with a time-sensitive condition like stroke, STEMI, trauma, and they can call in and speak to a physician up at Emory University, where I work. And that, the first leg of that experience is the physician providing direct, online medical control, right? Being able to have a conversation with the crew, provide orders if needed, interview the patient. We got pretty good at getting a virtual physical exam. And, that seemed obvious. That's the most natural part of telemedicine, especially when you can see all the vital signs and stream them in real time, and get a sense of what you're seeing in the patient in front of you. I would say the most value was with the second leg, which was actually facilitation of that patient's care. So the example I would like to use is, we'll call a small rural hospital and say, oh, you're getting a stroke patient. Symptoms started an hour ago. They're about 20 minutes out. You're the closest stroke center, even though you're not, comprehensive. Could you clear your CT table? Give me the number for your neurologist. I'll call and I'll give them the story. And here's all the patient's information so that you can get them registered in advance of their arrival. So all those little micro steps that we're taking and facilitating that patient's care is ultimately going to reduce the time to definitive care, right? Or time to intervention. And
right. And I mean, initially, of course, there's a learning curve with this, and people are going to say, well, you're spending more time on scene, or it's taking more time on scene. But to your point, by getting all of these things in place earlier, by the time they hit the hospital, it's a more seamless transition into the system. There's not the wait at the hospital as people are trying to funnel through, getting information, getting the consults, moving the patient to the proper destination.
Mm-hmm. Yeah. And you brought up a good point. We, early on, there was a concern that, if we took the time to evaluate patients on scene, that would extend the scene time and therefore delay care. Most of the time, though, crews were calling when they were already rolling. Crews knew where they were going. They knew the closest hospital. Oftentimes it's, in a lot of the counties we were working with, we're looking at 35, 40-minute drives. They had to get on the road. So the beauty of the noise canceling speaker was they could be driving lights and sirens down the road and we could still hear them. They could they could say things in very small voices. We could hear everything just fine. They could hear us despite the loud noises and chaos in the background. That actually, that's one thing that we started collecting data on early on. For a number of reasons, though, our data collection experience was foiled, pandemic being one, but also our EMS partner agency, started pulling out of rural counties, I think as a direct result of the pandemic. So we had a lot of turnover trying to develop new relationships and partnerships, which is just the nature of the business that you're in, right? In EMS.
So getting into the question of interaction with EMS crews, and the concern of, maybe having a little bit of big brother looking over your shoulder, how did they respond to having this additional equipment in their ambulances?
That's a great question. And there was a lot of regional variability between counties, especially. Some counties were entirely supportive and called for every single case, from lift assist to hypoglycemia. They were calling for everything and really got to embrace the technology. Other counties, there was a lot more hesitation about the new process and new change. There were several paramedics who saw it as a way to check on them, right? So a lot of it was managing change and going to visit those resistant counties in person and build relationships. A lot of it was giving examples of how we were using virtual care to enhance the experience. I remember specifically going down and we had a forum and they said, well, tell me how it could have helped this pediatric burn patient, right? We're not doing anything different in our care. We've got our fluid guidelines, we've got pain control, we're going to the burn center. How's that going to change this patient's outcome? So I could give the example of, well, yeah, you're doing the right care, and having a physician to bounce questions off of if something outside of that protocol or management came up. That's really the one piece of the puzzle. But the second value that's going to benefit the patient, I'm calling the burn center. I'm giving them the patient's information. I'm giving them the story. I'm telling them exactly what treatment we're initiating, exactly how much fluids we're starting, exactly what pain medicine they're getting. If there are any other concerns to the story, those are things that the physician can relay to the receiving team so that they're already ready and they know the story by the time you get there. And our experience, the hospitals really roll out the red carpet when the EMS crew arrives because they're entirely prepared. It seems to be a really positive experience overall. And I think it took a while for the crews to get that.
Right. And I can imagine you mentioned that, some crews, would call in everything and some would call in nothing. And, when it came time to hit that kind of happy medium and everybody was, on board and everybody's flowing through and I know you probably can't pull these numbers, but about how often were these services being used?
And again, there was a lot of variability from county to county. That goes on to say we actually have different models of deployment now in county to county. So one county, for example, Washington County, they are what we'd call a self-sufficient county. They actually use the physicians at their local county hospital. We set up the connection so that they could call in, report, and that physician who's going to be receiving the patient most of the time could weigh in on their guidance. If there was a subject matter expert need that was not available at that local county, they can loop in the Emory physician who can pull in, a subject matter expert from a tertiary care center. So that model is self-sufficient, and I would say that gets the most volume. They're calling their protocols now are to call for every transport to the hospital. So we could be approaching 100%. And last I checked, anywhere from, depending on the ambulance, 60 to 80, sometimes 160, depending on the volume and ebbs and flows in patients calling 911. That's where we see, pretty good utilization.
Right. So how is this impacting? I mean, because when you have quick transports, I would assume that, the benefit of this type of interaction could be limited versus your rural, like you mentioned earlier, ambulances that have 30-minute transports, 40-minute transports to hospitals where they could really benefit from this.
Yeah, you hit the nail on the head. The benefit of the system I described, where we've installed equipment in the ambulance, where the physician is providing that conversation and then facilitating care at the hospital. That really only works in a system where you have probably 30 minutes or more of a transport time to get to the closest hospital. Um, there is a role for telemedicine and virtual care in a metro area. We're actually investigating the best use for Metro Atlanta right now. For example, app-based notification of a pre-hospital arrival, right? So you can take out a lot of the phone calls and the phone trees and the handoffs and whatnot by automating the process. And especially in the case of time sensitive conditions like STEMI, stroke, those specialists who can see the patient, even though they're 12 minutes down the road, can start asking their questions about consenting for cath lab, for TPA, for other interventions, so that this is already done by the time they get to the hospital. That's still going to save time.
Right. Now, does your program deal? I mean, we've been talking strictly with the 911 type systems for community paramedic or mobile integrated health, whatever the agency is calling it at this time, where the care is, or the intent is not necessarily to transport the patient, have the patient safely at home and still get a consult.
Yes, we have one county, Chatham County, that we are a resource for their mobile integrated health team. And there are plenty of times I would say most recently in the wake of hurricane disasters, where we have Red Cross shelters, and that MIH team is actually deployed helping their enrolled patients who are hanging out at the Red Cross shelters, for example. We could help refill medications. We could weigh in on whether or not patients need to go to the emergency department. They also use us outside of disasters as well. But that's where I see the most utilization so far from those counties. But yes, this is a case use that there's a lot of interest about. And as agencies build MIH and CP programs, this is something that could really tremendously support them.
So, I mean, you're located in Georgia, and it seems, as you mentioned, there's a lot of counties that are using this in Georgia. Are you seeing this trend spread throughout the United States?
So I'm glad you asked that question. We actually are part of a network now that is ASPR funded. The Southern Regional Disaster Response System is a collaborative effort that is actually led by a PI at Emory University, Dr. Isaacoff, to pull in multi-institutional collaboration and develop resources and augment existing networks and support systems so that in a disaster, things can be mobilized a lot faster. We don't have to wait for, an emergency declaration or federal resources or assets to be deployed. There are mechanisms, for example, now our network as part of this disaster response system can be activated when a small, county has, let's say, a train derailment. We've been called for, mass pesticide exposures, and nobody knew really what to do. We could pull in a toxicologist or subject matter expert for something that we don't see too often in small communities. That network involvement has allowed us to share our experience across the Southeast, the Southeast HHS. So we could, work with other agencies and hospital systems to deploy a similar model to what we're doing. I've been contacted quite a bit in the recent past about collaborating to build similar programs. I have to say that most of them are still stroke oriented, or they have a very specific question or problem that they're trying to address. So stroke systems for sure. The multi-use network that we are striving for is, I would say, a little more rare.
Right. Well, just like with anything else, certain jurisdictions will identify the one need, and kind of dip their toe in it and see, and then it creates the opportunity of, oh wow, this worked so well with this, we could use it here or we could use it there. And as things change and rural medicine changes, you don't have neurology in a local hospital, and then maybe OB goes away from a local hospital, or cardiology goes away from a local hospital, and then we need this as well.
Mhm.
So adding on to the opportunity.
Yeah, it's building those relationships with the small hospital. That's really the core of building out successful programs, right? I mentioned early on we had grant funding, and that grant funding, the initial grant that I described, is actually over now. But we had other grant funded opportunities. We're striving to find different ways to sustain it at the state level. State appropriations. There are various mechanisms to keeping programs like this alive. It's not easy, but once people recognize that value and what you can add, and it's not just a doc in a box, on a screen. There's a lot more happening in the background. That's where I see there's a lot more adaption of a program like this.
Yeah. Well, this sounds great. So in last few minutes that I have you here, where are we going with this? What does the future hold? What's the capabilities, and what do we hope to be able to learn and to advance?
Like I said, the key for me is sustaining the network in a multi-use capacity, especially in the setting of disaster response. You want a network that's used every day, so that crews, EMS personnel using it are not trying to pull it out of a closet and hook it up and try to, get it to work when they need it. We want to incorporate virtual care into normal daily interactions in the EMS world. And it's not, again, the message that I try to send it's not replacement. It's not checking up on crews. It's enhancing the care, right? It's facilitating care for that patient, especially in the setting of rural, where 20% of the United States lives in a rural designated county. We see a need for that, and that's where I think virtual care can make a difference. The next steps is trying to figure out how to make it more scalable. So in many counties, we're abandoning the hard install. So the Cadillac version, where we've installed equipment in the back of these ambulances, that's really difficult to sustain. As you can imagine, ambulance gets in an accident, taken out for maintenance. We've got to move that equipment over to another ambulance. There are ways that we can do it, but it slows things down quite a bit.
Right.
And so figuring out how to be available for, just on a mobile device. We now have, iPhone, iPad access. You don't need the fancy equipment to call in and talk. The monitor streaming is not always required. So we're now just trying to use it more to figure out those nuances and find the best use, and ultimately hope to keep sharing our experience. We, have a manuscript coming up soon. I think we just need to keep talking about it to make it more normal, right?
Yeah. Well, and also too, I mean, as technology advances and we kind of are able to tweak it, best practices come out, cost goes down, better utilization of current equipment,
Mm-hmm.
will help facilitate those type of things. And a lot of times, you've got urban agencies using it, you have rural agencies using it. Somebody goes to look and you're like, well, that's not us. That's not who we are. We don't have their same problems, or we don't have their same budget.
Mm-hmm.
But there's something that's out of that group or out of that technology that, oh, we could use that. That is cost effective. That is a way for us to kind of get into it and then start expanding.
Yeah, it's not a one size fits all system. That's part of the
Right.
success of our program, is being, adapting to meet the needs of the local community. some counties have very poor connectivity. So we've deployed, mega range antennas to try to figure out if we could boost the cellular connectivity and really enhance that experience. So far seems to be working. And some counties, connectivity is great, but they have to drive for, an hour and a half to get to the closest hospital. And, you have to make sure the equipment is being charged on the way. If for some reason there's an issue with the power circuitry and the tablet stops getting charged, it'll just shut off in the middle of a conversation, right? So all these things you kind of have to figure out and be, and adapt.
Yeah. Well, Dr. Carr, thank you for joining me today. I really appreciate you taking time to talk about this. It's all really cool. And, during my career, I've seen, pieces and parts of this, and to have a system up and running is kind of exciting. I think there's a lot of opportunity for this, for standard 911, for community paramedic or mobile integrated health. You opened my eyes to the aspect of, potentially using it during disasters. So yeah, I think this is a great opportunity.
Yeah, it's really a cool niche to be working in. I think there's a lot that's going to change, and as we see regulatory changes supporting reimbursement, for example, that's where we're going to start to see a lot more agencies picking this technology and these various case uses up.
Yeah. Well, as you mentioned, just to start something like this, it's expensive. A lot of people go with grants, but, grants are not forever. You've got to figure out sustainability of these type of programs.
For sure.
Well, again, thank you very much. And we look forward to hearing more about this program. And, if you'd like to join us again with updates, we'd love to have you.
Well, I'd love to do that. Hopefully good news in the future moving forward. Thanks so much for having me, Ted.
Thank you.